The F word, frailty. So what is frailty? So think of frailty as a chronic disease or condition related to the aging process in which multiple body systems gradually lose their inbuilt reserves. And because of this loss of reserves, older people with frailty are at risk of unpredictable deterioration in their health, resulting from relatively minor external stress or events. So the older person with dementia and frailty moved from the familiar environment of their rest home to the unfamiliar environment of the emergency department is at risk of developing delirium. Another example of a minor external stressor is the prescription of anticholinergic drugs such as oxybutynin to treat urge incontinence. This drug has the potential to cause delirium, falls due to postural hypotension, and immobility due to constipation. The point is that the adverse consequences of these external stressors are predictable and therefore avoidable if you make the diagnosis of frailty. So what's the science? So frailty occurs because of an interaction between two things. Sarcopenia is low muscle strength with low muscle mass, which results in low physical performance. But you can have sarcopenia without having frailty, for example, cancer or other chronic diseases such as heart failure. If in addition to sarcopenia, a person has an accumulation of deficits, then that will give rise to the characteristic features of frailty, namely loss of reserve, impaired function, and this extreme vulnerability to relatively minor external stressors. A deficit can be anything from a chronic disease such as heart failure, or a symptom such as fatigue or weight loss, or social isolation or dementia. The more deficits you have, the more likely you are to develop frailty. So when older people with frailty become unwell or decompensate, they present with non-specific symptoms or syndromes. These presentations are absolutely typical for the older person with frailty and are known as the frailty syndromes, which are listed here. So immobility is a sudden loss of mobility, often referred to as off legs. Delirium is acute confusion or the worsening of chronic confusion in somebody with dementia. Incontinence can be urinary or fecal, and again can be new or worsening of chronic incontinence. Examples of susceptibility to side effects of medication would include delirium caused by opiates and anticholinergic drugs, postural hypotension caused by cardiac drugs, and constipation caused by opiates and anticholinergic drugs. Falls can present as legs giving way, collapsed cause, or found lying on the floor. Whenever an older person presents with one of these frailty syndromes, you should be asking yourself, do they have frailty? Because frailty is common, and the prevalence of frailty increases with increasing age. Put another way, that means that each year, MidCentral admits about 4,500 patients with frailty, and that 2 out of 3 patients over the age of 90 is likely to have frailty. Understanding the hazards of inappropriate bed rest and hospitalization in the older person with frailty is important. When a functional older person with acute illness is hospitalized, they're exposed to a variety of external stressors. An alien environment for one, medicines, and often many of them, procedures. They're at risk of malnutrition and dehydration because they're not able to ask for help with eating and drinking. And prolonged bed rest and immobility leads to a loss of muscle mass, i.e. sarcopenia. And this occurs very quickly in older people with frailty. For every day in bed, older people lose 2 to 5% of their muscle mass. So all of this can cause delirium, physical impairment, and deconditioning, resulting in a dysfunctional older person in as little as 24 hours. So as I said earlier, older people with frailty lack reserve and are incredibly vulnerable to external stressors and therefore to the adverse consequences of these stressors. So immobility can lead to pressure injury. Inappropriate prescription of drugs that cause sedation or postural hypotension can cause a fall and hip fracture. Inappropriate hospitalization can cause delirium. And all of these adverse consequences will increase the risk of death and disability. So what can you do to better manage older people with frailty? The first thing is to screen for it. In MidCentral, we are recommending the combination of the timed up and go test plus the Prisma 7 questionnaire. If the timed up and go test is greater than 13 seconds and the Prisma 7 questionnaire is 3 or more, they're very likely to have underlying frailty. And this combination has good sensitivity and specificity. So incorporating frailty screening into routine practice encourages a proactive approach to its management and will identify those patients who will benefit from a comprehensive geriatric assessment, which is the evidence-based management of frailty. This step is absolutely vital to identify physical, psychological, social, and financial issues, and then to develop a coordinated and integrated plan to address them. The third thing is to try to prevent the complication of loss of muscle mass and deconditioning. So patients should be encouraged to sit up out of bed when they're having their meals. They should be encouraged to dress up in their own clothes. And they should be encouraged to walk at regular intervals, either with an aid or without, with assistance or without. And clearly, staff and carers will have an important role to play here. So in MidCentral, we've adopted this mantra of get up, get dressed, and get moving. So in summary, think of frailty as a chronic disease characterized by loss of reserve and extreme vulnerability to relatively minor external stressors. Be very suspicious when you see an older person present with any of the frailty syndromes, and remember to screen all older people over the age of 75 for frailty, and if positive, start the comprehensive geriatric assessment as soon as possible so that you can develop that integrated, coordinated care plan. And finally, to prevent the complication of loss of muscle mass and deconditioning, remember to get your patients up, dressed, and moving.